Hello everyone, my name is Amir, and these are our tips and tricks for medial to lateral dissection and low anterior resection. My couple of disclosures that I wanted to give off the hop. The first is that obviously these are not really my tips and tricks. These are the tips and tricks that I picked up over the last 2 years from working with the wonderful staff at St. Paul's Hospital during my fellowship, so I want to thank them. And the second is that there's obviously many ways to do this operation, lateral to medial, medial to lateral. There's many tips and tricks within the medial to lateral approach as well too, and one should be familiar with all of them. So having said that, here are a few of our tips and tricks. The first is to just go over the anatomy. The idea here is that, shown in this picture, is that this is the inferior mesenteric artery coming off of the aorta, and the idea is to get underneath this vessel and sweep the retroperitoneum away from the vessel. I'll just point out that the left colic artery branches off of the inferior mesenteric artery, and the superior rectal artery goes down and supplies the rectum. A high ligation is when you take the vessel just distal to its takeoff from the aorta. So medial to lateral is not new. It is a technique that was actually in some ways proposed by Turnbull, who is one of the founding figures in the Cleveland Clinic, who talked about the no-touch technique, and it's one of the most cited papers in colorectal surgery. But the laparoscopic approach allows us to do this medial to lateral approach with enhanced visualization in a way that is hard to do open, and also employs the CO2 insufflation to really delineate where those planes are. So here are the steps. Deliver the sigmoid colon out of the pelvis, score the retroperitoneum, bluntly sweep away the retroperitoneum, identify the left ureter and gonadal vessel, sweep away the hypogastric nerves, make a window, divide the vessel, and sweep the retroperitoneum away from the mesocolon. Again, these are not novel steps. They can be found in any textbook or video on medial to lateral dissection. What I'm going to show you are some of the tips and tricks that I've learned over the last 2 years from my fellowship. The first is that it's the rectum that you want, so you really have to deliver all the sigmoid colon out of the pelvis. You need to start lower than you think. Consistently, when I started doing this, I would start my dissection higher than was probably the right plane. And you really want to be almost between or just above the right common iliac. You want to keep your friends close and your enemies closer. You want to go low to go high and take advantage of the situation, and don't be stubborn. So you're going to see all those steps here in a moment. So this is an example dissection. Here we're scoring underneath the IMA pedicle. Again, we start fairly low. We've delivered the sigmoid colon out of the pelvis, and we're scoring this peritoneum on the medial side. Our assistant is grabbing the sigmoid colon to keep the floppiness away. Obviously, this is a very thin patient, and you could actually see the left ureter vermiculating there in an earlier shot. You want to keep your friends close and your enemies closer, the enemy being the IMA here. You want to stay right under the IMA pedicle. All the nerves go down. And a really important key component to doing this dissection laparoscopically is to really give strong tension with your left hand, the hand that is not doing the retraction, up towards screen left. And so here you can see that there's a little bit of blood, and one of my tips was bleeding is bad. So anytime there's even a little bit of blood, you have to question if you're in the right plane. And there you saw that we could visualize left common iliac, and that is an indication that we've gone too deep. And so the maneuver here is to actually try to get the plane reestablished. And to do that, we see the left common iliac again. To do that and reestablish the plane, we're going to withdraw our left hand and try to open up that window even further. And now you can see that we've found the right plane again. That's the white line of Tolt that we're pushing down. You can see the difference and how that's not exposed. Another good tip for knowing that you've gone too deep is if you see the psoas muscle, you've gone too deep. It's really important to have a really wide window when doing this medial to lateral dissection. You don't want to work in a tunnel. So we're opening up the rest of the peritoneum underneath the vessel that we have tented up. And again, we're going to sweep all the hypogastric nerves away. Those are all the nerves that are important for bladder and sexual function, as well as bowel function. And you can really see that line, white line of Tolt, the line separating retroperitoneum quite nicely, and we're sweeping that away. The sweeping motion is again supposed to be kind of a C motion, sweeping in broad strokes down. And I was just pointing out there where we'd gone too deep. There's the ureter that you saw vermiculate again. So take advantage of the situation. As much of the dissection as you can do from this position will help you to gain length when doing your anastomosis. So a lot of people think of the length being gained by dissecting the lateral attachments of the colon, but it's really actually separating all the retroperitoneal structures off of the mesocolon where you get your maximal length, and of course also taking the IMA pedicle high and taking the IMV as well. So now we're going to take the vessel, we're taking the peritoneum over top of it. I just want to point out that here we're not doing a high ligation, we're taking the pedicle just distal to the left colic takeoff. There's no real oncologic benefit when doing a low anterior resection of taking the IMA pedicle, but of course it's very important that one consider taking the IMA pedicle flush with the aorta or just distal to the aorta if you really want to gain maximal length on the colonic conduit. That's my tip about go low to go far. So here we are taking the vessel with the ligature device. You can take it with clips, you can take it with the stapler. We tend to take it with an energy device. Here is the ligature. Again, we don't have any disclosures with respect to the company. It's just what we happen to use. You can use any vessel sealing device that you choose. And we're going to again try to exploit that retroperitoneal dissection, make sure that we have enough length. I should mention this video is a video of a fairly thin patient in which the patient already had two synchronous lesions, a right colon cancer as well as a rectal cancer, and so we've already done the right colon dissection, and now we're doing the low anterior. And so you can see this nice purple hue here of the tissues that indicates the dissection that we've done from below. We're going to break into that eventually and get into our medial dissection. So here's another case where things don't go exactly the way we want it. So remember, it's the rectum that we want, and this patient has some adhesions which are tethering the sigmoid colon into the pelvis and are not allowing us to completely dissect it free. Another clue here is that you can see some tattoo on the IMA pedicle, but it's not immediately clear to us that that's actually the IMA pedicle. So again, it's lower than you think when you're starting the dissection, but we're worried that we're going to get under the retroperitoneal structures, which is a reasonable thing to be worried about. Here we're actually starting our dissection under the left colic, although we think it's the IMA. You can convince yourself here that you're dissecting the right plane. It almost sort of looks like an avascular plane. It almost looks like there's the retroperitoneum that you're sweeping away. But it's too thin. And it's too easy to get into the right spot and get into the sidewall. Yeah, like the caption says, it was too easy. So this is the time not to be stubborn, and it's time to go lateral. So here we've gone lateral. You can obviously see we've done a bit more dissection that I've edited out for sake of time. Here we're taking off all the remaining lateral attachments. You can see the ureter there, and you can see these sidewall attachments. This patient, again, we're doing the low anterior resection for cancer, but the patient must have had some episodes of diverticulitis or has some congenital adhesions in that plane. Now we're actually establishing the true plane under the IMA pedicle. And in a moment, you're going to see that we establish the correct plane towards the mesorectum. I'm bluntly sweeping away the retroperitoneum here. Again, just being careful as we're still not quite sure of the anatomy here. But this is a good video that indicates all the principles that I tried to illustrate. You really want to start low. You want to deliver all the sigmoid colon out of the pelvis. Keep your friends closer and your enemies closer. Bleeding is bad. And there you have it. Those are our tips and tricks for medial to lateral dissection. I'd love to hear your thoughts and comments on the video. Thanks again.